So the original lecture for this was created by my fellowship program director, Noel Wagner, back a while ago when the state of Michigan was getting ready to kind of change their spinal motion restrictions that we just recently, within the last 5 years or so, instituted. So what we're going to do is go through some of the science of kind of why we don't backboard and C-collar as much as we used to. As is typical, I don't have any conflicts of interest. So we're going to talk about some of the major types of spinal injuries first, talk about some of the statistics, why we would, do spinal motion restrictions. And then we're going to talk about, some of the pros and cons of putting people in these restrictions. And then go over the spinal injury assessment and spinal immobilization protocols. So I think all of us that have been doing this long enough remember from back in the day where, we basically would backboard and C-collar anybody that sneezed funny. And there were times where the patient, I'm sure, probably felt like this, boy, all I did was get into a car crash and look at me, I'm strapped to a hard plastic board. And can barely breathe. So hopefully by the end of this, you'll have a better appreciation for why things had to change. Typically we don't like change in EMS, and fortunately that never changes. I think the fire service is also, pretty reluctant to institute change. It's always worked. So this is kind of the first EMS. This is from, I believe, World War II. We see kind of all the components. We've got the EMTs and paramedics with their stretcher. We've got another EMT kind of attending to the wounded, another one there. Okay. We've got the police officer standing around looking good. He's got his sword right at his side. We've got some other police officers kind of off in the background, I guess, controlling traffic. Okay. And then, we've got the paramedic or the medical director, of course, just standing there and pointing for the EMTs to do all the heavy lifting. So, we don't like change. Doctors always say, well, that's not how I learned how to do it. I'm guilty of, saying that myself. Nurses, that's not the way I did it when I was in EMS 30 years ago. And then paramedics and EMTs and firefighters, I think, are a little more blunt, which is actually why I really like hanging out with you guys. You just come out and say, that's stupid. That's their version of saying, I don't like the change. We've always done it, this way. So the birth of spinal immobilization kind of came around in World War II. So you can see here, they've got the regular carry stretcher, they used to have, along with this wooden kind of platform that they would lay in it and then strap the patient to that wooden platform and tape the head back, it looks like, onto that wooden platform. They were nice. They put a towel roll, and it looks like it has a little kind of hinge there so you can get better thigh elevation. I guess make it a little more comfortable on the patient. So in 1966, based on some of their experience in World War II, Colonel Kossuth first described the use of the long backboard to move a victim from the vehicle with a minimum of additional trauma. So I want you to take note of that. Move a victim from the vehicle. And his conjecture was such movement was to occur with due regard to maximum gentleness. Interesting way of putting it, but okay. We saw through the 1970s, Johnny and Roy, emergency captivated the country. We started to see what a modern EMS system begins to look like with, two highly skilled paramedics, with medications and lots of treatments and things like that for the rest of the country weren't available yet. But this is what really began to get the government's interest in, getting a modern EMS system up and running was the pressure they received from, TV show like Emergency. Farrington, J.D. Farrington was very famous. He published this report called Death in a Ditch from the American College of Surgeons in 1967. And that was kind of one of the other big catalysts for the development of EMS. And even he said, in this paper, the most frequently mishandled injuries made worse by hasty and rough movement from a vehicle or other accident scene are fractures of the spine and the femur. So we've now got, a medical publication also saying, hey, we probably ought to immobilize, these spinal fractures, et cetera. So it really took off kind of in the 1970s, where we had EMS systems beginning to add in, some of the spinal motion restriction stuff. It really accelerated in the 1980s, not in small part due to the 1984 DOT curriculum, where it was mandated that to receive federal funding, you had to follow this curriculum. But this whole time, it was anecdotal. It was all from, hey, this kind of makes sense. If somebody breaks an arm, we immobilize it. Well, if somebody breaks the spine, we should probably immobilize it. But it was never proven and slowly became the standard of care as time went by. So even, to this day, there really aren't any definitive studies that show that it's beneficial, which I know is crazy, but you also have to keep in mind, fracturing an arm is a way more simple fracture. It's only involving one or two bones, typically within the arm. And it's something that you can immobilize fairly easily. The spine is a whole bunch of bones that are all designed to move against one another, even in very small motions, to allow us to move our back. And so it's much, much, much harder to get those sometimes to heal up. We also now know that there are several studies that we're going to go over here that suggest that, spinal immobilization is bad, that it actually worsens things. So first, let's talk about the spinal cord. So everyone knows this, the spinal cord runs in our back. It's a bundle of nerves that basically runs from our brain all the way down to, a certain level within the back. And then those nerves connect with other nerves that then take the system, or the stimulus out to the rest of the body. It provides both sensory and motor control, et cetera. It's held together kind of by this, spinal complex that has the vertebra along with the intervertebral disc that separates the two bones from actually touching, along with the facets and the rest of the back that protect it kind of as a cage. And that cage is where we sometimes will see some of these fractures. The good news is a lot of the time with these, kind of fractures around the cage, et cetera, a lot of the time, it doesn't really cause any instability. It doesn't allow things to, suddenly move drastically because it typically affects only one of the facets instead of both of them. But it provides excellent protection for that spinal cord. At the same time, though, because it's fairly tight back there, any type of bleeding that's going to occur anywhere within that column has the potential of beginning to put pressure on, the spinal cord. The same with, anybody who's had, disc problems like myself, that intervertebral disc can bulge backwards and, begin to put pressure on the nerves back there, which, doesn't feel great. So one of the first spinal fractures we want to talk about is neural arch fracture. Okay, this is typically a hyperextension injury. So this is one of the ones that we sometimes will see in sports. It's a longitudinal fracture through the posterior neural arch, usually bilateral. The neural arch of C1 is compressed between C2 and the occiput. So let me get my annotation thing out. So in this particular case, we can see that fracture right there. What's interesting is it also looks like there may be a fracture of C2 as well. But you can see that little faint line right there that shows that there's a fracture there. That, unless it's bilateral, is not necessarily always going to be an unstable fracture. We still would typically treat it at the hospital with kind of a padded collar to help keep the patient from moving too much, but it's never going to stop all of the movement. Come on, advance. All right. The next one we're going to talk about is the odontoid peg fracture. And this is the most common fracture of C2. And it may be caused by flexion or extension and usually results in some sort of ligamentous instability. So in this particular instance, let me get my annotation thing back up. Come on. Come on. All right, well, hopefully you can, there we go. So you should be able to see that slightly kind of right in there, okay? So if you see there's that line, nature doesn't generally tend to like straight lines. And so anytime in an x-ray that you see a straight line, that's usually not, you know, something that they're supposed to have. That's an indication of a fracture. And what happens is the odontoid basically fractures off of kind of the top of C2. The odontoid is what allows your head to kind of rotate around like that. And it holds the skull kind of from basically falling forward off of you. And so this is a pretty bad type of fracture to have. These patients are actually one of the ones where immobilization may help, but we're going to talk about another type of injury that we will sometimes see where it could actually hurt things. Sorry. I don't know why it's there. We go. So in a hangman's fracture, we are getting the exact same kind of injury. It's fracturing the odontoid, but it also takes out the pedicles of the odontoid. And so what happens is, you know, the noose kind of is supposed to get put around, you know, way up high on the person's neck. At least if you're a good, I guess, executioner. So the noose would, you know, kind of go this way. And the goal of a good, you know, executioner was to get that force transmitted through here. Because what happens is it kind of, you know, crumbles the vertebra. And so part of the vertebra, you know, goes forward, part of it goes backward, and severs the spinal cord. And, you know, a lot of people, when they were hung, hopefully got this kind of an execution because it basically leads to pretty swift death. It severs the spinal cord, you can't breathe, and you very quickly lose consciousness. It also typically caused vascular injury, which probably contributed to things. But we still will see injuries like this, typically from the same kind of mechanism. Somebody who tries to hang themselves at home or gets clipped by something while riding a motorcycle, et cetera, we will still see these fractures. Unfortunately, some of these fractures, you know, the patient's dead by the time we get there. But in other times, you know, it's not a complete severing that occurs. And, you know, they will survive, but they're going to be ventilator dependent. They're going to be a full quadriplegic, et cetera. It's a pretty rough life. You know, if you had a bad executioner, they would put the rope down really low. And instead of a very swift death, down here, the bones are much bigger and, you know, less likely to break. And so what happens then is you basically have to be strangled to death by the rope. So not a very pleasant way to go, is to be up there struggling for minutes. Let's talk about burst fractures as well. Burst fractures are one of the ones that we sometimes will see in auto accidents as well as, you know, falls. And basically what happens is a big axial load gets put, so some sort of a load down kind of the column gets put, and it splinters the vertebra out into multiple different pieces, kind of in a starlight pattern almost. And in this particular one, you can see right here. Okay, and then if you look also, you can kind of see there's some tilting and some lines there, like especially this one here, that's not really present in the other vertebra. And so these sometimes will cause partial paralysis. Oftentimes they will just cause pain. And oftentimes we are able to avoid having to treat these surgically, but some of them do end up needing to go to surgery. And generally that's so that we can kind of put the bone back together as best we can, and or putting a cage kind of around the spinal cord to prevent any pressure from developing from bones, that are moving. This person is going to be in a back splint. Obviously we can't put people in full body casts, much to the cartoons and movies chagrin. But we typically would put someone in a plastic kind of back brace that minimizes their movement and allows this fracture to heal. Oh, come on. I think I'm just going to use the PowerPoint pointer thing. So this is that same fracture. And in this case, you can see that burst, unfortunately, caused the, in this particular case, it caused the bone here to kind of go posteriorly, and it's now compressing the spinal cord. The spinal cord is supposed to look like this up here, where, there's cerebrospinal fluid, which is the white, and then the nerves are dark because they've got less water. And in this case, it's been retropulsed, and unfortunately, this patient is likely experiencing quite significant pain. They may even, depending on what level this is at, begin to have signs and symptoms of cauda equina, where they're beginning to get paralyzed kind of from the hips downward. Not a very good thing. Whenever we talk about spinal cord injuries, it's important that we know at what level the spinal cord injury occurs. That is going to tell us, what kinds of things are going to occur to this patient as a result. What level are they going to be paralyzed at? Is that going to affect, breathing, movement of the mouth, control of the airway, bowel bladder function, things like that. So when we go through and, analyze the patient, not only is imaging very crucial, but so is a thorough neuro exam. We kind of divide the spine up into the major areas that can fracture, which are cervical, thoracic, and lumbar. We tend not to see sacral fractures all that often. When we do, they are often very bad, but they tend not to affect the nerves quite as much, because at that point, most of the nerves have exited your spinal column. As you can see here, it's pretty extensive. The ones to think about, though, are C3, 4, 5. There's an old adage, C3, 4, 5, keep the diaphragm alive. Those three nerves bundle together and go down and innervate your diaphragm. So if you have a fracture, involving C3 or C4, you may begin to have difficulty breathing. Okay. And if it's above that, you won't be able to breathe. So if you're going to have a fracture, of your cervical spine, you want it definitely below those three, myotomes, because otherwise you're not going to be able to breathe, and you're going to be 100% vent dependent. There's also the sensation that's really important. And, the way a lot of people will divide things out when we're trying to do a very quick sensory exam is, C3 is kind of the collarbones, okay? T4 is roughly the nipples. T10 is roughly the umbilical cord area, okay? And then when you get down here into L4, L5, if they can feel you, over the kind of greater toe area, that's where you can say, okay, great, they've got sensation all the way down in that spine, so it's less likely they're having compression up higher than that. Every year in the United States, about 10,000 people are injured with a traumatic spinal cord injury. This predominantly affects males under the age of 50. The whole, hey, hold my beer, watch this, unfortunately leads to a not insignificant number of these. 36 to 48% of these are from motor vehicle accidents, and about half of all of them involve the cervical spine. And this tends to cost the U.S., upwards of $3.5 billion per year in added medical expense. That's not including, kind of all the downstream effects. Is this person going to be able to work again? If so, how productive are they going to be? Are they going to be able to support, a family, support their ongoing medical needs, things like that. And so the dollars add up very, very quickly. Among severely traumatized patients, meaning these are the worst traumatized patients, 2 to 5% of them had cervical spine fracture, and 1 to 2% of them were unstable fractures. So to put things in context, this is still an extremely rare thing. If 2 to 5% of all the severely traumatized patients have some sort of a C-spine fracture, and only 1 to 2% of those were unstable fractures, we're talking about a relatively low percentage of patients that are going to have some sort of an unstable fracture. Those that had a known unstable cervical spine fracture, half of them demonstrated some sort of neurologic deficit upon hospital arrival. So most of these are going to be apparent to us out in the field. Those patients that have a known neurodeficit require spinal immobilization. But the conjecture is EMS should be concerned with 0.5 to 1% of the severely injured population having one of these. And so by backboarding everybody because of 0.5 to 1% of the severely injured population, that's a lot of patients that we're backboarding unnecessarily. So as far as detecting the spinal cord injury, 4.6% of trauma patients that had a C-spine injury had a missed or delayed diagnosis that resulted in preventable mortality and morbidity. So essentially, some of these patients will have a delayed presentation. We're going to talk about the forces needed to fracture the bones, but they will have a delayed presentation. And a lot of the time, we will find on autopsy in these patients that they have significant bleeding within the spinal canal. And so, yeah, the bone itself may not have, severed the spinal cord or compressed the spinal cord, but it tore one of the vessels that supplies the spinal cord, which then leads to, bleeding into that very tight area. The bleeding then puts pressure onto the spinal cord, and effectively, that's what's doing the paralysis, not the bone itself. Another study showed that spinal cord injury without fracture was low, 0.7%. Those tend to be, hyperextension injuries where the spinal cord itself will get bruised or damaged instead of there being an actual fracture with it. And those are notoriously difficult to diagnose. You basically need to get an MRI in order to prove that indeed is what's going on. The rate of missed C-spine injury was lower at 0.01%. Like I said, most of these patients are going to be, having neurodeficits when we get there or while we're transporting. So why did we do, spinal motion restriction for so long? The idea was to prevent any aggravation of any type of a spine injury that's unstable that could worsen injury to the spinal cord. And so just like with, immobilizing an arm, if we immobilize the spine, that's good. That means that it won't, quote, move, unquote, and, continue to move the fracture and allow the fracture to heal. The other idea is we're preventing this movement from occurring, and it also limits our movement during the extrication. Okay, so this is what we've been doing for forever, is going in with these ideas. So, EMS gospel for so long was, if there's a concern, immobilize. If you're in doubt, immobilize. If you think somebody's going to yell at you, immobilize. I think all of us, myself included, are guilty of putting people on backboards and C-collars, et cetera, just simply to avoid, the wrath of the emergency department when you drop off this patient and they say, well, why didn't you backboard them and C-collar them, et cetera. Hopefully, by the end of this, you'll have some of the science behind it and can say, well, not only was it because of my protocol, but it's also because of X, Y, Z. So is this gospel correct? Is this foundation that we need to immobilize everybody? Is this based in reality, or is this just superstition? Should the backboard be kind of the voodoo of EMS? Just like, the black cat and the broken mirror. So the spine is really strong. It needs to be really strong. It's carrying all of our weight, plus it also protects the spinal cord itself. And so it needs to be strong to prevent, when we get into a fight with the saber-toothed tiger, injury to the cord, which is going to, eliminate us from, the reproductive chain, Darwinism, For a C-spine to be fractured, it requires between 2,000 and 6,000 newtons of force, which equates basically to 450 to 1,350 pounds per second that need to be applied. Lumbar spine fractures are more than 4,200 newtons, or more than 945 pounds. So it's a significant amount of force that needs to be put focally in one area to cause this kind of a fracture. All right. So why don't we just simply immobilize everybody? We could, and we used to immobilize almost everybody. And we now know that comes with risk: airway compromise, aspiration risk, intracranial pressure, pressure ulcers. It causes pain and can make moving them more difficult. The patient may be calm and collected, but the moment we strap them down, they become combative or resistant. It also can delay our transport. When we take 20 minutes to really secure the patient to a KED board and things like that, like we used to do, when they're bleeding out in their belly from a spleen laceration, that's ultimately going to kill them. Was the KED board, needed? And is this stuff effective? So skin ulcerations are one of the big things that can come from backboards, and they form as early as 20 minutes within. Anybody who has, taken a nap or fallen asleep kind of in a hard chair, et cetera, before, will sometimes wake up with kind of red spots on your elbows, et cetera. And those red spots are the beginnings of skin ulceration. Okay. Without knowing it, all of us are constantly kind of shifting around a little bit in our seat, because the skin needs blood flow just like every other organ of the body. And as we shift around, we're causing compression to certain areas and perfusion to other areas. Well, if we've got somebody who is paralyzed, they don't have the ability to shimmy themselves around and move around. And so instead of that skin only being ischemic for, a couple of minutes, instead, until someone else moves that patient, that skin is going to be ischemic. It's going to begin to die off. And unfortunately, that just progresses until you get something really, really difficult like this to deal with. So this was a really interesting study that was done between the University of Malaya, I know it's from Malaysia, and the University of New Mexico. All right. So they're comparing basically Malaysian EMS to modern US EMS. Okay. So one of the interesting things about Malaysia is they actually have really good kind of modern hospitals. So the quality of care in the hospital is pretty equivalent to what you're going to get here in the United States. But they don't have anybody, to pick people up and bring them to the hospital. So there's really no robust EMS system that is going to do immobilization and things like that. So, the University of Malaysia doesn't have EMS, and so no spinal immobilization is going to occur, whereas University of New Mexico, EMS was providing 100% spinal immobilization to these spinal injury patients, okay? So we're really looking at, is the immobilization, preventing further injury? And the result was that actually the patients that got immobilized did worse. So they got worse as a result of being immobilized. And there's a 98% probability that immobilization is harmful or of no value. We also refer to this study sometimes as the pickup truck study, because this study, really kind of raised the question of, are you safer being chucked in the back of a pickup truck like you are in Malaysia and driven to the hospital versus, very judiciously backboarding, C-collaring, KED-boarding, somebody, et cetera, and then getting them to the hospital. And this study raised the question of, wait a minute, we may need to rethink things. So why is this that the immobilization may have little effect? Well, movement within the spine takes very little energy, okay? But fracturing the spine requires a significant amount of injury. So any spinal movement after the injury, is going to transfer that energy to all of the component parts. So the bone is going to help reabsorb this, the ligament, the muscles, the disc, et cetera. And that minimizes movement on any one part. So instead of the force being applied across one area, it's now being applied across a broader area, okay? Whereas when we immobilize somebody, we've now theoretically stopped movement except at very specific points. So all of that force gets transmitted through that single point instead of across the spine. We also have some thoughts that immobilization may cause tissue hypoxia to the injured area. The spinal cord needs to move somewhat to circulate the cerebrospinal fluid, et cetera. And so is that potentially contributing to these worse outcomes? We also know that, taking the time to put somebody in a C-collar or backboard delays treatment and transport. So what do we do now? All of us at some point in our life came across something like this, if you've been doing this long enough, where, outside the ambulance entrance to most hospitals, there was this, herd of backboards that were missing their ambulances. And it was always fun to kind of see, which agency was the furthest away. We sometimes would get agencies that we didn't even recognize, like, where the heck is, Cook County, or, I think Denton is on there. Yeah, Denton Fire Rescue. Where the heck is that? They may have come from way far out, especially if they got flown. So everybody is always concerned about, kind of the liability around this stuff. The personal injury attorneys advertise very heavily about this stuff. And there's concern that, oh my God, if we don't immobilize somebody, they're going to say that we're the ones who caused the spinal cord injury, because we didn't immobilize them. When the reality is, the spinal cord injury is a result of the accident. It's not a result of any movement, et cetera, that you did. It's a result of the accident and the immense amount of force that gets applied to the spine. So let's talk a little bit about cervical collars. Are they effective? So this was a study that was done in 2011. Cervical collars are insufficient for immobilizing an unstable cervical spine injury, okay? So this was a laboratory study, meaning, this was not on real patients. 5 lightly embalmed cadavers. I'm honestly not exactly sure what lightly embalmed means. I'm thinking that they were meaning with this like they're relatively fresh. But to me, embalming is either an all or none. You're either embalmed or you're not. Anyway, they tested out 3 major different collars, etc., and none of them worked adequately to prevent motion where we wanted to prevent motion. Another article, Journal of Trauma, August 2010, extrication collars can result in abnormal separation between vertebrae in the presence of a dissociative injury. So this was basically talking about a specific type of fracture called cranial caudal dislocations, similar to those C2, C1 fractures we talked about earlier. So they evaluated the movement and the biomechanics of these types of fractures on cadavers, coupled with multiple different types of cervical collars. And they found that this led to 7.3 millimeters of separation. So that's 7.3 millimeters that we are now stretching the spinal cord because we put the cervical collar on. It's kind of shoving up on the bottom of our head, pulling on the spine. We also call this one the snow cone study because think about it. When you are a kid and you've got a snow cone that comes in the little traditional triangle cup, etc. If you were not careful and you squeezed on it, your snow cone would pop off, right? Well, this is kind of the same thing just on humans. We put this rigid thing around their neck, and as we're applying it, it's now pushing up on the bottom of our head, and that's not good when you've got one of these dislocations because there's nothing there to prevent it at this point from basically completing the spinal cord injury. So this actually can make things a lot worse. And this is kind of an example of one of the people that they did this to, or one of the cadavers they did this to. So this is how that particular person started, okay? So you can see here, it's obviously there's fracture, it's not exactly aligned perfectly, etc. But then when they put the cervical collar on, this is what it spread out to, okay? And in this particular patient, it looks like it was 15 or 16 millimeters maybe, which is pretty significant. I mean, that's over, over a centimeter, and that's a lot of stretch to put on the C-spine. All right, so what about backboards? Are they effective? Well, we know from taking care of enough, drunk patients over the years that, a violent or agitated patient is going to continue to fight whether there's a backboard or not. We used to use back in the day backboards to restrain these patients. We don't do that anymore, okay? But if we've got somebody who's kind of like one of those, happy but injured drunks, and they suddenly freak out when we start to put them in a C-collar and we strap them down to a board, etc. Now this person is struggling against all this stuff. Well, what do you think is going to cause, more injury to the spine? Them sitting quietly, on a stretcher, or them struggling against a cervical collar and or backboard? The belligerent drunk is going to be way better off sometimes just being left alone and not being immobilized. Cooperative patients are going to lie still if they're asked or if it hurts to move, okay, regardless of whether there's a backboard or straps present. So are there other negative effects of these backboards? Well, yeah. Pre-hospital emergency care, that's our EMS journal. This is where a lot of the big time EMS studies get published. This was in 1999, and it was a lab test again with 39 volunteers. So these patients were not injured. They used both vacuum mattresses and backboards to simulate this. And 15% of those patients underwent some sort of respiratory restriction. So healthy people had difficulty with breathing because of how they were put on the vacuum mattress and the backboard. 2002, changes in physical examination caused by use of spinal immobilization. So they took 20 healthy volunteers that didn't have any history of a back pain or back injury previously. So we're comparing healthy patients, okay? They had midline palpation at 10-minute intervals. So they would basically log roll them off of whatever it was, feel up and down their spine, and then put them back in position, and did that every 10 minutes. 18 out of the 20 of them had increased pain at 60 minutes, which led to increased false positive exams. Okay, so remember, these are healthy people that do not actually have an injury. 18 out of 20 of them had increased pain at 60 minutes. That's not an unreasonable amount of time for somebody, to be on a backboard. If you think about it, all right, we're going to have 10 minutes maybe on scene that we've gotten them now strapped to the backboard. Let's say it takes us, 20 minutes to get to the hospital. So we're now at 30 minutes. Let's face it, the hospitals are overrun right now, and sometimes it takes some time to get attention and to get this person. And so 60 minutes can come and go relatively quickly before this patient gets removed from the backboard. And what happens with that? Well, all right, we took somebody who didn't have back pain before, and we very likely induced back pain into them. What happens when you show up to the ER after some sort of a trauma and you have back pain? We take pictures of you. We're going to put you in the CAT scan and get pictures of your C-spine, potentially your lumbar spine, et cetera, looking for fractures. So this was studying that in 2012, pre-hospital emergency care again, potential adverse effects of spinal immobilization in children. And this was a prospective trial, so they enrolled patients as they went along for 13 months. A total of 173 kids were immobilized as part of this. There were 112 that were not immobilized, but met the immobilization criteria, meaning, for some reason they did not get immobilized, but should have been immobilized. And this was only on the immobilized patients that were studied. They had a higher degree of pain, more radiographic studies, and a higher admission rate. And that all may be simply because of the backboard and C-collar. We did more studies, more x-rays, more CAT scans, et cetera, on these kids that had back pain. And we admitted them at a higher rate. And the reason we probably admitted them was because they still had some back pain, and we needed to get an MRI to prove that they don't have a spinal cord injury, to go with it, or a ligament injury to go with it. So let's kind of pivot a little bit. Most of what we've been talking about, really is blunt trauma, which is where we're going to see, the majority of all of these types of spinal cord injuries. Generally, penetrating trauma, we don't tend to see a lot of spinal cord injuries because the injury is occurring in such a focal area that unless it's involving the spinal cord itself, it's really unlikely to, cause any problem with your spinal cord. So there's no evidence that, immobilization of penetrating head, neck, torso trauma, is going to prevent anything. Whereas blunt head injury increases the risk of cervical spine injury by 6 times. Okay, so yeah, in that situation, it does make a difference. So Journal of Trauma, 2010, spine immobilization and penetrating trauma, more harm than good. So this was 45,284 patients. All of them were taken from the National Trauma Data Bank. This is a big nationwide data set that is collected by the American College of Surgeons. Every verified trauma center in the country uploads de-identified patient data on injuries, outcomes, treatments, et cetera, to see if we can make any sense of a bigger data set. Part of that also includes our reports. Our reports get uploaded as part of this by the trauma registrars at trauma centers, okay? So they only looked at penetrating trauma. the mortality overall was 8.1%. Okay, so remember, penetrating trauma, mortality 8.1%. But 14.7% immobilized versus 7.2% not immobilized. So immobilization may have led to a doubling of the death rate. That's not good. The odds ratio for death was 2.06, so just a hair over 2 times the risk of dying if you were put on a backboard from penetrating trauma. 30 out of those 45,284, 30 of those patients had an incomplete injury, okay? The numbers needed to treat, this is the number of patients that we need to treat before we get to one potential save, okay, is 1,032. We have to treat 1,032 penetrating trauma victims before we get one potential save, okay? But it only took 66 patients to harm, okay? So that meant a 15-to-1 ratio. So we're going to injure 15 patients for every one that we may end up, benefiting. That's horrible. We're going to harm 15 patients to potentially get one save. That's pretty bad. So another one, Journal of Trauma, October 2009. Pre-hospital spinal mobilization does not appear to be beneficial and may complicate care following gunshot injury to the torso. Okay. So this was a retrospective chart audit again, specifically GSWs to the torso, 357 patients in a single hospital over 41 months, plus 75,210 patients from the National Trauma Data Bank collected over 60 months. Immobilization had no benefit. Okay, another one, Journal of Trauma, unstable cervical spine fracture after penetrating neck injury, a rare entity in an analysis of 1,069 patients. So 1,069 patients, these were both gunshot wounds and stab wounds. Unstable cervical spine injury incident was very, very low, of 0.4% of that population. Those were only seen in the GSW patients. Okay, if you think about it, it's a much, much, much more forceful impact than a stabbing. And they still found the same 15-to-1. Okay, so we harmed 15 patients for every one that we potentially saved. So 2 different studies now studying very different things that are otherwise penetrating trauma. That's pretty damning. We injure 15 patients for every one that we're going to potentially help. So another study, September 2011, pre-hospital spine immobilization for penetrating trauma. And this was recommendations from the pre-hospital trauma life support committee. So these are the folks that come up with, this is how, PHTLS is supposed to be taught. These are the things we need to focus on. No studies exist to support the use of spinal immobilization in patients with penetrating trauma, yet it's widespread, okay? Only one case report has been published in the literature documenting an unstable cervical spine injury from penetrating trauma in a patient without spinal cord injury. That's pretty darn damning, okay? And so PHTLS, at this point, does not recommend routine spinal immobilization for penetrating trauma. And the only time that you really should be doing it is, when they have a focal neurologic deficit, like, hey, I can't move my legs, or hey, I'm having trouble breathing, etc. Those are the kinds of patients that may benefit. But otherwise, somebody who doesn't have any neurodeficit, there's the very real potential that you're going to harm the patient by putting them on a backboard. So still to this day, there are no randomized clinical studies, that exist. We have several studies that show increased mortality with immobilization, and we really don't see any demonstrated benefit. If anything, we've shown harm. So PHTLS now teaches against it. They are no longer recommending routine immobilization for penetrating trauma as a result of kind of all the science. So what has changed? All right. We really need to go back to the 1940s, where backboards were originally intended for getting patients off the battlefield and to an ambulance or to, you know, the medical center. Okay. We need to go back to using backboards for extrication only, and only when other means are not, you know, really acceptable. We can remove them. We should remove them after we've gotten them to the softly padded, you know, ambulance stretcher. We can remove C-collars, of course, whenever there's an airway or extreme patient distress interfering with our care. Okay. We really, really, really need to encourage self-extrication. You know, if you think about it, if my back is hurting and I move a certain way, I'm not going to move that certain way. Okay. So I'm going to be able to self-extricate, you know, out of that area with minimal pain. We don't feel their pain. Okay. We're trying to just get them out of whatever situation they're in. And so guess what? Even if it hurts like heck, we're still going to pull them through that. Well, pain is an indication that something bad may be happening. And so we may actually be making things worse when we, you know, extricate them ourselves instead of having them get out of the vehicle and sit down and lay still on the stretcher. We don't want to tape the head either. Hopefully my video of me is big enough that you can see me, but think about it. If you tape the head down, we know that the rest of the body isn't very well secured to a backboard. And so we've just done this, you know, where the rest of the body can kind of move and the cervical spine now suddenly becomes the pendulum. Okay. So all of the force of that movement is now being transmitted through the cervical spine, which is the thing that we're potentially trying to immobilize. We need to be able to move the airway as needed. Okay, so you should not worry about, you know, needing to remove a cervical collar, et cetera, or moving the patient's head to secure an airway. It's highly, 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 highly unlikely, and probably would get published if, you know, you were to worsen somebody's cervical spine injury by securing their airway. So let's take a look quickly kind of at our protocol. So this is the head and spinal injury, you know, trauma protocol. And it only mentions here once, immobilize the patient with full spinal precautions as per T704 spinal motion restriction protocol. Elevate the head of the bed, top of the backboard whenever possible. Okay. That's the only place where it's mentioned in the head and spinal injury protocol. So the head and spinal injury protocol says we've got to assess the scene to determine the mechanism of injury. Okay. So this would be motor vehicle crashes, okay, automobiles, all-terrain vehicles, snowmobiles, ejection from a vehicle, auto versus pedestrian or bike at more than 20 miles per hour. So again, these are all very high velocity, high force injuries, axial loading injuries to the spine, like diving, or falls that are greater than 10 feet. This is all a heck of a lot of force that's required to potentially, you know, fracture something, and is something that we're not going to be able to reproduce ourselves. You know, so the amount of force needed is minimal, or I'm sorry, is still fairly significant for us to cause an injury. We want to assess the patient in the position that they were found for their mental status, if they've got any spinal pain or tenderness, if they've got any extremity weakness or numbness, even if it's now resolved. So, you know, anybody who played football remembers, you know, the stingers, et cetera. So somebody whose arm was numb, you know, but has now resolved. Okay, that person had neurodeficit that was fairly focal. We may need to consider immobilization. Is there any evidence of intoxication? And by intoxication, I mean drunk, okay? Not the guy who's had 3 beers at Buffalo Wild Wings on Friday and is now, you know, walking out to his car. That is not, you know, intoxication in and of itself. Are there other distracting injuries like a bilateral femur fracture or a bad ankle fracture, et cetera, that are preventing the person from potentially paying attention to their spine. So if we've got any of those, we then go through kind of this checklist. Do they have an altered mental status? No. Okay, great. Midline neck or spine pain or tenderness with palpation? No. Great. Move on. Any focal or neurologic deficit? No. Any evidence of alcohol or drug intoxication? No. Is there any distracting pain? No. Are you having a communications barrier? Are they Nepalese and we're not able to speak with them in English? No. Great. Patient can be transported without spinal motion restrictions. If we get yes to any of these, then all right, we're probably going to apply a C-collar. All right. If they're ambulatory, we allow the patient to move to the stretcher, okay, into a seated position, and then we lay them back gently, right? So all of us probably when we were taking, EMT classes for the first time had to learn how to do those standing backboard takedowns, Don't do that. It's ridiculous. It's not, the patient is up and walking, etc. It's highly unlikely that somebody who's up and walking, is going to have any type of spinal injury of consequence. If they're non-ambulatory, we should use a backboard or a scoop stretcher or a vacuum mattress, but I'm not aware of anybody around here carrying vacuum mattresses to move the patient to the stretcher with minimal motion. We then should get them off of that backboard unless doing so is going to delay transport a significant amount, or there are other treatment priorities, like we need to get control over this bleeding, we need to get an airway established, things like that, okay? There are 3 circumstances under which raising the head of the bed to 30 degrees should be considered, and that's if the patient begins to develop respiratory distress. Okay, it takes some of the weight off of the person's diaphragm and makes it a little easier for them to breathe. If we have suspected severe head trauma, again, preventing any further pressure buildup in the head, or for promotion of patient compliance. If having the person elevated to 30 degrees calms them down and makes them, more comfortable, great. We should probably, do that as well. So we say very explicitly within the protocol that patients with penetrating injury to the neck should not be put in a C-collar or other spinal precautions, whether they are exhibiting neurologic symptoms or not. By taking that time to immobilize them, that can lead to a delayed identification of the injury or an airway compromise, that may develop. So it's really, really, really important for us to keep them out of that C-collar. We may miss that they've got this expanding mass of blood under their skin because it's covered up by a C-collar. So we very explicitly also say don't transport patients on rigid longboards, unless absolutely necessary. Longboards, if you're going to use them, should be padded or have a vacuum mattress supplied to minimize secondary injury to the patient. Spread that, pressure across a bigger area. There really is no evidence that manual stabilization is going to, prevent an injury when the patient's alert with spontaneous head and neck movement. We don't need to manually stabilize the patient. So the whole, I'm going to climb in the back seat and, hold somebody's head really, really, really still, who's otherwise looking out at the window at me and moving around and things like that. We don't need to do that. They've cleared their C-spine already. So we can just let them self-extricate out of the vehicle. Patients who are not likely to benefit from immobilization have a low likelihood of spinal injury, should not be immobilized. So that's most ground level falls. Okay, when grandma falls down, it's still pretty unlikely that grandma, even with osteoporosis, is going to fracture their spine. Ambulatory patients can be safely immobilized only on the stretcher, maybe with a cervical collar and straps, but generally they're not going to require a spine board. They already are demonstrating that you know, by holding themselves up and walking around, that their spinal cord is working just fine. Thank you very much. Reserve long spine board use for the movement of patients whose injuries limit ambulation and who meet criteria for the use of spinal precautions. Remove them from that long board as soon as it is practical. Questions? I know that was a lot of information to go over in the brief period of time that we had, but hopefully it was fairly high yield, and hopefully you now have a better understanding of kind of the science behind why we have gotten so far away from spinal immobilization. So any questions? Nobody asks questions anymore. This is why I like doing these live. People tend to ask more questions. All right, well, if no questions, we can go ahead and